And this is the last section, and then we're going to talk about two more opportunistic infections pretty briefly, but I do think it's important to kind of see a viral example and an example that is bacterial. First, again, just a slide that shows potential bacterial opportunistic infections. And we haven't talked about mycobacterial infections yet, but I did want to talk today about Mycobacterium avium complex, and we will talk about the M. tuberculosis complex in a couple of weeks. So the complex is actually made up of a couple of organisms. The two most common are avium and intracellulare. They are ubiquitous, meaning that they can be found all throughout our environments, and they can actually be acquired by both HIV positive and HIV negative people. But because this is an opportunistic infection, we would expect that it's going to be much worse and much more likely to be clinically significant when we're dealing with severe immune compromise. There are two forms. One is disseminated, meaning it can be found throughout the body, and one is focal, meaning you can usually only find it in the lymph nodes. We're going to be talking mainly about the disseminated form, and how this is transmitted is either through inhalation or ingestion. So person to person and common source transmissions are relatively rare. This is more a person getting it from the environment. And again, this is most commonly seen in people who are HIV positive, but in this case, it's most commonly seen in somebody who's got a very low CD4 count at less than 50 cells per microliter. This is pretty rare in the age of art, just like all the other medications, but it does still occur. What we're seeing currently is that in the US, it's usually less than 2 cases per 1,000 person years if a person is in care. I've seen this very often, and every time I've seen this is with somebody who either was never tested for HIV despite ongoing risk factors because they either knew they had the disease and they just didn't want to kind of face it, or it was somebody who was diagnosed with HIV, but we could never get them to actually take their antiretroviral therapy, and their CD4 count got very low. So this is an ugly condition to see when it happens. It is very much preventable, but unfortunately, there are still cases, even right here in Western New York. And there is a genetic variability. It's most common in the southern US than it is in Canada or the northern US. And it's actually more common in the US than it is in Europe. And one of the things I will say about some of the people that we have dealt with in our clinic are that they have moved back to Buffalo after being in the South for family reasons or because of their health. Whatever the reason was, they moved back. So it is seen in the northern US, but a lot of the cases we saw in our clinic were people who had moved back from being in the South. Recent acquisition is most often in the case of illness. So we are actually not seeing examples of latent infection because the organism is actually killed. Manifestations of this are usually very nonspecific, and these symptoms will look familiar when we start to talk about tuberculosis as common to all mycobacterial infections: fever, night sweats, fatigue, weight loss, diarrhea, abdominal pain, coughing, diffuse lymphadenopathy. One of the things that's interesting about the difference between the focal that we talked about on the previous slide and diffuse is that because this is all of the lymph nodes, it might actually be missed. And if you're looking at lab abnormalities, we will be looking at things like anemia or an elevated alkaline phosphatase or lactate dehydrogenase. Diagnosis is usually through an abdominal CT, but to really diagnose, we should be looking at isolation of the organism in blood or the lymph node. I will say that we have, in a number of our cases, tried to do stool samples to try and get a Mycobacterium culture. And it does happen in some cases, but it's usually not quite as valuable than the organism, finding the organism in blood. And just to give you an example, and we'll talk more about this when we do talk about the other mycobacterial infections, the cultures are very, very slow because these organisms are very slow growing. It takes upwards of 7 to 10 days before you can get the culture back. How do you treat it? We usually are going to use combination therapy. So as one kind of hint, the mainstay of therapy is a macrolide. So we're talking about MAC infection. We're going to be treating with a macrolide. The two examples that are out there are clarithromycin 500 milligrams BID or azithromycin 500 to 600 milligrams a day. Obviously, it's easier to take once a day than it is twice a day. Most of the data that we have does support the use of clarithromycin BID, but we are seeing more in the current age of treatment of these conditions that the azithromycin 600 milligrams a day reduces drug interactions and side effects, and it allows for increased adherence. So it might actually be just as effective, if not more effective, than that clarithromycin. So it is possible to use both, but we have to consider what's best for our patient while we're doing this. Because we're always using combination, because just like with HIV, we don't want to risk resistance by using one medication. The second drug we're using is ethambutol, and the dosing is 15 mg per kg. We can potentially add rifabutin if patients are not started on antiretroviral therapy or they're failing their ART, or if they've got a very high mycobacterial load, we might. And when ethambutol is not tolerated, we would actually use rifabutin as the second drug. But you're never going to be treating somebody with a macrolide alone. They should have either ethambutol or rifabutin on board, or in cases where there's a real concern, both. And if there is a macrolide allergy, which again is relatively rare, you would use ethambutol and rifabutin together. Most people who do use that combination of ethambutol and rifabutin would actually add a quinolone to make sure that they're getting the power of the antibiotic. Treatment is at least 12 months, and in all cases, susceptibility testing has to be performed because there is a chance that resistance can happen. And again, like I said with HIV, combination therapy reduces the risk of resistance, which should help. So for patient monitoring, when we're dealing with clarithromycin, we want to consider drug interactions, the GI upset, and the fact that it's twice daily dosing. With azithromycin, the GI side effects are relatively rare at lower doses, but they still can occur. And this can also cause QT prolongation, but it is daily dosing. And remember, daily dosing is for treatment. When we get to prevention, that's going to change a little bit. Ethambutol can cause rash, liver function elevations, and optic neuritis. This is actually seen at higher doses or if it's used for long periods of time. So this is usually not preferred as one of the mainstays of a number of conditions. Ethambutol does potentially reduce red-green color discrimination, and we don't tend to use this in children because it's very hard for children to understand what you're asking them when you give them the test for color blindness. Rifabutin is a good drug. It is known for drug interactions and can cause an orange discoloration of body fluids, but the other main concern is that it could potentially cause some liver function elevations. Much more rare when it's used without other drugs that cause liver function elevations, but it still can happen. And what we're looking for is an improvement in the fever curve within the first 4 weeks. And if that's not seen, we're going to send repeat blood cultures. And again, with any blood culture we do for this organism, we're going to try and do sensitivities when we get the results. Secondary prophylaxis. So once we've treated for 12 months, the regimen is continued for 12 months, but it can actually be longer if there is no immune reconstitution. So that treatment is actually for people who have a CD4 count greater than 100 for at least 6 months before they're allowed to discontinue it. And then we're going to reinstate treatment if the CD4 count falls below 50. And for treatment-naive patients, ART therapy should be started within a few days of starting MAC, just because we do want to prevent, we want to do everything we can to boost the immune system. In a treatment failure, the next regimen is going to be based on drug sensitivities. So it's always important to get those with every blood draw that's done. Primary prophylaxis, for a long time, for anybody who had a CD4 count less than 50, we would rule out an active MAC infection and then start them on azithromycin. We don't do that anymore. So we are not recommending primary antimicrobial prophylaxis in somebody who is at risk for MAC because the risk in MAC is relatively low if they're starting potent antiretroviral therapy. And this would also reduce the risk of adverse events, drug interactions, or drug resistance. In patients who refuse or who are unable to start antiretroviral therapy, we should start it. And one thing to keep in mind is that we should be ruling out active MAC before we start prophylaxis. The reason for that is that the regimens that are preferred are macrolides. So macrolides by themselves, if you're using the prevention doses to treat an active infection, you're going to wind up with resistance. So you have to rule out that active infection before you start prophylaxis. The regimens that are preferred are azithromycin 1200 milligrams once weekly. So you can imagine that's great for people in terms of their adherence. One problem is that at 1200 milligrams, you do start to see some of the GI upset that can cause some problems here. If that is an issue, we have changed the dose to 600 milligrams twice a week as an alternative and found that to be very helpful. So we would usually recommend that they start with the 1200 once a week. And what we would do if they couldn't is we would schedule their twice weeklies on Mondays and Thursdays. Alternatively, they can do clarithromycin 500 BID. You can imagine that's a nightmare when it comes to side effects, drug interactions, and adherence. And another alternative, if macrolides really are a problem, is rifabutin 300 milligrams daily, but that is definitely known to be less effective than macrolides. So in any chance you have, you would probably want to do macrolide. But we are now in a circumstance where they don't necessarily need to do it, because if we start them on medications for antiretroviral therapy, it's expected that their CD4 count is going to go up. And if it goes up, the likelihood of them having the disease is, the MAC is unlikely. So we don't need to recommend prophylaxis anymore. And then if we're dealing with viral opportunistic infections, again, there's a whole bunch of them, but the one I want to consider today is Cytomegalovirus, and we're going to be considering only the retinitis that it can cause. This is the most common ocular complication of AIDS. CMV can also cause localized disease in a number of areas of the body, but what we're going to talk about today is just the eyes. Before antiretroviral therapy, it was seen in 25% of people who had HIV/AIDS, and now there's an 80% reduction in cases. Slower rates of retinal progression, ocular complications, and improved survival after diagnosis are all seen with people who get started on antiretroviral therapy appropriately. I have again seen this quite a bit, and the unfortunate truth is that we see this most often in people who are not adherent to their HIV medications or who never found out they were diagnosed with HIV until they had already progressed to AIDS. The majority of illnesses are related to reactivation of latent infections. So this is another one of those reactivations rather than the new onset illness. And this is again seen in people who have no idea what their serostatus is or are not willing or able to take their antiretroviral therapy. CMV is usually transmitted from person to person via blood fluids, or body fluids rather. So that includes saliva, urine, tears, semen, and breast milk in addition to blood. One interesting thing to keep in mind about this is that more than 90% of people who are dealing with this are going to be organ transplant recipients, IV drug users, and men who have sex with men. Almost 90% of them, more than 90% of them, are going to be positive for their IgG when it comes to CMV. In immune-competent people, this may still show minor symptoms at the time of infection, and those will include fever, sore throat, fatigue, swollen glands. That's supposed to say mono-like symptoms, not moon-like symptoms. These aren't steroids. And hepatitis. Retinitis will occur from hematogenous spread from the CMV, from the organs and the blood into the eye. And other risk factors are going to be a really high CMV viral load. Anybody who's been using steroids and chemotherapy and radiotherapy for cancers or blood transfusion. What happens with CMV in the eye is that it can cause a full thickness retinal necrosis and swelling. And when the swelling and the dead tissues of the retina are kind of cleared from the system, there's going to be a very thin atropic scar. The scar tissue is susceptible to tearing, and that can actually lead to detachment of the retina, which can lead to vision problems and blindness. Without antiretroviral therapy or any sort of immune reconstitution, those lesions can enlarge, and as they enlarge, they start to impinge on the retina and the optic nerves, and they cannot regenerate functionally. So manifestations are going to be things like blurring or loss of central vision, There's going to be blind spots, floaters, and flashing lights. And typically this is going to start in one eye, but will progress to the second eye if not treated. And this will eventually lead to vision loss. Despite the fact that you can actually do retina reattachment in surgery, the vision is never the same as it was beforehand. So if we can prevent this from happening, all the better. How we diagnose this, we're going to diagnose it based on what the ophthalmologist sees. And what they can see are yellow, white, fluffy, or granular retinal lesions. So it's very important that anybody who is HIV positive is recommended to see their eye doctor at least annually. For people who have a lower CD4 count, we recommend that they are seen at least every 6 months. And if a person has negative CMV IgG, that greatly reduces the likelihood that they're going to have this infection. So just like with toxo, we usually will at baseline get a toxo and a CMV IgG for their baseline labs. We'll test those every time they come in to get their blood work done to make sure that they are staying either negative or if they're negative, hopefully they're staying negative. But the hope is that, you know, when somebody comes in and they've got signs or symptoms that look like cytomegalovirus or toxo, if their CMV IgG is negative, we have to really consider what the other differential is, because it's not likely that it's going to be these conditions. How do you treat it? We're going to use antiviral therapy, which could be either intravitreal, which is exactly what it sounds like. It's a shot into the eye, or systemic. Immediate sight-threatening lesions should be given both systemic and intravitreal treatment, and those who do not have an immediately sight-threatening lesion should be given systemic therapy alone. The drugs of choice are valganciclovir. Please note that that is not valacyclovir, which is used for, say, HSV. The dose is 900 milligrams BID for 14 to 21 days, and then you transition as secondary prophylaxis to 900 milligrams a day. If you have to use an intravitreal injection, the one that's usually used is ganciclovir, 2.5 milligrams times 1, or even weekly for 2 to 3 weeks. And as alternatives for people who can't tolerate valganciclovir or ganciclovir, there's the potential to use foscarnet. If a person can't tolerate oral valganciclovir, you can use IV ganciclovir or foscarnet, or the potential to add IV cytomegalovirus. So again, because these are drugs you haven't really seen too much of before, I want to go through a couple of things about them. One of them, valganciclovir, can cause neutropenia and thrombocytopenia as well as diarrhea. Neutropenia can be reversible if you're using GCSF. The dose does need to be adjusted for renal insufficiency, and what's nice is that valganciclovir is a prodrug of ganciclovir, but the bioavailability, even though it is higher than IV ganciclovir, is still only about 60%. Intravitreal ganciclovir and intravitreal foscarnet can actually cause toxicity to the retina if the dose is too high. So it's a fine kind of balance. And if you're using IV ganciclovir, thrombocytopenia and neutropenia are again very common. So they have cutoffs where if the person has platelet counts that are very low, you should be watching. And also if there is any sort of neutropenia, starting GCSF. IV foscarnet is, again, a pretty ugly drug. You're dealing with nephrotoxicity, electrolyte imbalances, the potential for genital ulcers and fluid overload. One of the things that helps prevent the risk of nephrotoxicity is the use of boluses of normal saline before the first dose. And this one can actually cause infusion-related issues with hypocalcemia, which can cause tetany, paresthesias, arrhythmias, altered mental status, and headache. So again, this is one of those drugs that if you're using it, it really should be in an ICU setting, or at least in the setting where telemetry is possible. And IV cidofovir can cause neurotoxicity, proteinuria, neutropenia as well. And we should be avoiding this one in sulfa allergies because it is related to a drug that can cause sulfa allergies. When it comes to secondary prophylaxis, so after a person has been treated for their condition and their sight is no longer there's no threat to their immediate sight, we're going to switch a person over to valganciclovir 900 milligrams a day. This can be discontinued if all of the following are met. They have quiescent retinitis. The lesions have been treated for at least 6 months. the HIV viral load is suppressed and the CD4 count goes above 100 for at least 3 months. They're going to restart it if the CD4 count falls below 100. And due to the low risk of CMV retinitis in people who are taking antiretroviral therapies, and the fact that these drugs all have very severe adverse events, there is no primary prophylaxis for this condition either. So there is the risk of possible relapse. Usually those relapses happen in the absence of an immune reconstitution because of the HIV medications. There also could be poor resistance or poor adherence to the medications themselves. And what we have seen is that healing of the initial retinal lesions might strengthen the blood-retina barrier and block the drug from crossing into the vitreous areas, which could actually make it harder to treat. So that was a quick overview of 5 different conditions that are related to opportunistic infections. And the reason I chose those was because they tend to be pretty common in people who have not taken their medications, but also they are examples of different organisms that could potentially cause issues, but also different disease states and different organ systems that might be involved. Again, if there are questions, please do let me know. I know that the last couple of days there's been a lot of information. I will give you slides and cases to work through. I'll give you examples of questions that might be asked on the exam to help you through it. But I am always open to talking about this. If you haven't been able to tell, this is one of my favorite things to talk about. So if you are somebody who's interested, please do give me a call. And I hope that you are well and that you and your families are all staying well. Have a good day. Bye-bye.